So again, welcome everyone to those who have just joined. My name is Noelle Rohatinsky, and I will be moderating tonight's very informative session. Our topic for tonight's webinar is the challenges of managing IBD in the aging population. We have two esteemed presenters tonight who I will introduce in just a moment. Um, but we will go through some preliminary slides with some introductions and information, and then we'll start into the formal presentation. So next slide, please. I'd like to start us off in a good way and acknowledge the lands in which we are joining from tonight. On behalf of the Canadian IBD Nursing Board, we want to take a moment to acknowledge the Indigenous people of all the lands that we are joining from virtually today. We recognize the importance of the lands in which we call home, and from coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Next slide, please. So tonight's webinar is hosted by CAN-IBD, and CAN-IBD is a consortium of nurses across Canada working in the field of IBD and is supported by Crohn's and Colitis Canada. So for those who are joining us for the first time tonight, welcome. Our vision is to ensure people of all ages living with IBD in Canada receive high-quality clinical nursing care within a multidisciplinary team. Next slide. CAN-IBD is committed to improving the quality of care for people living with IBD by providing mentorship and learning opportunities to IBD nurses in Canada, creating opportunities for networking and sharing best practices, developing and adopting nursing guidelines and standards for IBD nursing in Canada, and elevating the profile of IBD nursing in Canada. Next slide. Today's webinar, as I mentioned, we have two presenters. The first presenter is Dr. Yusuf, and Dr. Yusuf obtained his doctorate of medicine from the University College Cork in Ireland. He completed his internal medicine and gastroenterology residency at the University of Toronto and an advanced fellowship in IBD at McMaster. He has a general gastroenterology practice with a focus on complex Crohn's diseases and ulcerative colitis in Mississauga, seeing patients in his private practice at West GTA Endoscopy and at Trillium Health Partners Credit Valley Hospital. Dr. Yusuf is a lecturer at the U of T Faculty of Medicine and co-director of West GTA Research for Clinical Trials. Next slide. And our second presenter is Dr. Shiv Khosla. Dr. Khosla is a geriatrician with Trillium Health Partners in Mississauga. He obtained his medical degree and subsequent training at the Royal College of Surgeons in Ireland, Bay State Medical Center in Massachusetts, Duke University Medical Center in North Carolina, and McMaster University in Hamilton. He worked for several years in Kitchener-Waterloo prior to relocating to THP in Mississauga. He is the physician lead for post-acute care in geriatrics. He has led the rollout of novel treatments for Alzheimer's disease at THP. His special interests outside of general geriatric care are novel biomarkers and treatments for dementia and maintaining health span in aging. Before we begin, I just would like to thank all of our supporters so far this year, and the three are listed there on the screen, and specifically a special thank you to tonight's sponsor, Organon, for this webinar. So thank you to them. In terms of logistics related to the presentations for tonight, you'll see at the bottom of your screen or somewhere on your screen a chat box or a Q&A box. You can type your questions into that, to either of those boxes, and we will get to them at the end of the session. And there will be some time for Q&A following the presentation. So with that, I'd like to welcome our speakers and thank them for their time so far.
Thank you so much, Noelle. Very, very kind words. Appreciate the introduction. And thank you, to CAN-IBD for having us. Wonderful, wonderful organization that I just hope continues to grow and continues to be impactful across the country. Also, again, I will echo thank you to Organon for ongoing sponsorship, especially for talks like this, which are very, very important, from an educational perspective and not necessarily drug related or specifically drug related. So thank you for that. Let me just pull up our slideshow here, and I'm going to um, let me just share my screen first. And then I will switch this over here. Is everyone able to see the slides clearly?
Yes, we
Okay,
can.
excellent, great. So we'll begin here. Just opening up on the introduction that Noelle kind of graciously gave for us. I've been working at Trillium for about 5 years now, with a primary focus in inflammatory bowel disease, which truly is my interest. And although I'll see all IBD, including complex IBD, I think some of the most interesting populations in IBD are really special populations. Whether it's pregnancy in IBD, whether it's transitions from pediatric to adult care, but very much also geriatrics in IBD, the care for elderly populations, because this is where oftentimes there's a paucity in data. A lot of times these individuals are excluded from clinical trials, and data certainly underrepresents these folks. So we do have data in general about kind of the core, age groups, 18 to maybe 70, 75 sometimes. But outside of that, that's where the art of medicine comes into play. It's something that I see as one of the participants, Usha Chauhan. She's hopefully listening in tonight from CAN IBD. She was one of my mentors when I was an IBD clinical fellow at McMaster University about 5-6 years ago. And so a lot of what we're going to talk about today will be some of the data that describes this population, the aging population, but we'll also talk about the art of medicine and the art of caring for this very special population. These are my disclaimers overall. It's basically that we'll be discussing data that is publicly retrievable, but I'll be presenting my opinion as well. These are my typical disclosures. These are Dr. Khosla's disclosures as well. And these are our goals. So today we're going to talk about epidemiology a little bit. We're going to talk about some unique considerations for treatment in the elderly IBD population. We'll do a couple of cases. We'll review some efficacy and safety data, and we'll finish off with some best practices overall. In terms of the slides, we're going to go through them pretty quickly in a relatively conversational fashion. So, at any point, if there's something that you want to pause and expand on, certainly interrupt me or just pop something into the chat, or we can discuss it at the end. And, because this is a virtual event, I'm not going to open this up necessarily for a big conversation at this point, but I just want everyone to pause and just, before we get into the actual data, maybe just think about this idea, in general, what the first line of treatment might be in the elderly population for somebody with ulcerative colitis. If they have mild to moderate ulcerative colitis, it's probably a no-brainer. 5-ASAs are the staple. But if they have a flare in the elderly population, are we perhaps leaning a little bit more towards budesonide? Are we thinking about prednisone? And then moderate to severe ulcerative colitis, out of the classes that we have, which are anti-TNFs, anti-integrins like vedolizumab, IL-12/23s like ustekinumab, the newer kids on the block, the IL-23 specific inhibitors like mirikizumab, guselkumab, risankizumab, and upadacitinib. All of these are theoretically not particularly well studied in the elderly population, but certainly available and covered. But are we leaning towards one or other classes in general for the elderly population when compared to, say, somebody in their 30s, 40s, or 50s? And similarly for Crohn's disease, it's actually a little bit harder when we're thinking about mild to moderate Crohn's disease. 5-ASAs are quite safe overall, but really their evidence, especially now in 2026, is much, much more limited. It's really seen to be an ulcerative colitis drug. But we still sometimes might opt for that in particular patients over methotrexate or azathioprine, the immunomodulators, in the elderly population. Similarly, what steroid might we reach for in times of flare, and which advanced therapy classes might be those of choice for elderly individuals with inflammatory bowel disease, specifically Crohn's disease. So keep that in mind. Just have a thought about which of those categories you might lean to, and let's see if presentation of some of this data might change some of those perceptions that we might have about one class versus another in terms of efficacy, safety, and appropriateness for treatment of the elderly population. From an epidemiological perspective, Canada has a huge burden of inflammatory bowel disease, almost more so than anywhere else in the world. Maybe a couple of other Scandinavian countries with similar incidence and prevalence overall. And currently, we have about 0.8% of the population, or 325,000 individuals in Canada, with inflammatory bowel disease. And when you look at projection models, looking out to 2035, which really isn't that far away, that's anticipated to rise to about 1.1%, which looks very marginal, but really isn't. We're talking about an additional 140,000 individuals with inflammatory bowel disease, or almost 500,000 Canadians to treat a very expensive disease. Of course, incidence is unfortunately rising amongst pediatric populations overall, but prevalence is rising most rapidly in the elderly populations due to not only new onset diagnosis in the elderly, but also ongoing life expectancy for those who have pre-existing diagnosis, and with better therapies in aging populations, the longevity of individuals even with complex IBD who are elderly is actually quite good. And so currently there's about 1 out of 88 seniors within Canada with inflammatory bowel disease, and a lot of those are brand new diagnoses, with 10 to 15% of all new diagnoses occurring in individuals age 60 and older. And overall, the cost of these types of care for the elderly is much, much higher across all different types of disease, but very much for IBD, based on the fact that they have comorbid conditions. There's issues with frailty, higher and longer length of stay in hospitals, and we'll review some surgical data, but oftentimes, depending on the subset of the population, higher rates of surgery. And this is basically the numbers that were predicted by the world's most and Canada's most leading epidemiologist for inflammatory bowel disease, a guy named Gil Kaplan, who's out in the prairies. And you can see that although the elderly population there, that blue line at the very, very top makes up a small, it's still quite a significant proportion of the overall prevalence of IBD, but certainly growing overall. So not insignificant, and something that we are challenged with in clinic all the time. And one thing to keep in mind, is this idea of the STRIDE-2 guidelines, this idea of treat to target, which does not reflect just stopping at clinical response and just making people generally feel good. It's also expands on the idea that the serum and fecal biomarkers can be very, very helpful at understanding the true disease activity over and above clinical symptoms, with the goal of ideally trying to get an individual not only to clinical remission, but ideally to mucosal healing overall, where their colonoscopy actually looks quite good, with a lot of data that demonstrates overall much better short, medium, and long-term targets overall, whether it's the goal of reducing hospitalization, reducing flare frequency, flare severity, malignancy. All of these types of outcomes overall are achieved much, much more readily with mucosal healing. But that's just, a guideline, and guidelines work well for simple cases. They work well for people who fit within the box of populations that are most commonly studied. And the question is, do these guidelines are they relevant for individuals who are of more advanced age? And the answer is sometimes absolutely yes, but other times maybe perhaps not. And again, this brings me back to the idea of the science of medicine, which we're going to go into a little bit, but then we're going to talk about a little bit of the art of medicine and treating a patient as an individual rather than just, a number. Multiple challenges that we're going to build upon with respects to IBD diagnosis in the elderly. So the actual diagnosis can be a little bit trickier sometimes, because sometimes they can't even just get to the diagnostic themselves. There might be an access to care issue overall, including mobility issues, transportation challenges, dependence on caregivers, and maybe a reliance on virtual care or preference for virtual care rather than in person. They might have personal mobility issues. Just trying to take bowel preparation is really hard for all patients, but perhaps even more so for individuals who are a little bit older. Colonoscopy itself just might be more tiring. It might take longer to recover. Sedation is a little bit more labile with individuals who are a little bit more elderly. We also have to think about, other challenges in terms of diagnosis, such as they might have a little bit more atypical symptoms. They might have more weight loss that might be attributed to other issues. They might have confounding factors of anemia that might be related to anemia of chronic disease or other comorbid conditions. They might be more susceptible to delirium, and these patients are often more susceptible to functional decline overall. This is somewhat of a diagnostic algorithm that was published in gastroenterology a number of years ago, about 4 or 5 years ago, by a pretty well-known guy named Anant Krishnan, who's out of Harvard. Their group suggests that this is a reasonable approach for more elderly individuals with symptoms that could be suggestive of underlying chronic gastrointestinal issues. So if there's relatively low suspicion based on those symptoms above, like chronic diarrhea, rectal bleeding, weight loss, or abdominal pain, with maybe not all of those characteristics being experienced by a patient, if the suspicion for inflammatory bowel disease from the onset is relatively low, they do recommend evaluation for other causes, of course, but more so reliance on non-invasive biomarkers up front, such as fecal calprotectin, very, very early on, to try to distinguish those individuals who might benefit from colonoscopy versus those who you might steer in a different direction of diagnosis to try to get to a different direction in terms of diagnostics and in terms of trying to get to the actual diagnosis. Of course, for those with elevated biomarkers, including fecal calprotectin, they do recommend going on with biopsy or colonoscopy with biopsies to confirm the diagnosis. And of course, those with very, very typical presentations should go on straight to colonoscopy without prejudice, without delay, without withholding that type of diagnostic tool, colonoscopy, in individuals who are elderly. Especially because there are a number of other alternative diagnoses that are more common in elderly populations that can mimic inflammatory bowel disease, such as microscopic colitis, which is its own beast and will have a totally different treatment algorithm. Ischemic colitis, given higher rates of underlying vascular disease. Segmental colitis associated with diverticulosis, so not just the diverticulitis, but actually that patchy colonic inflammation, not within the diverticulum itself, but in the adjacent mucosa, where you actually might treat with sometimes antibiotics, but actually kind of a hybrid of treatment of some IBD medications and other just etiologies in general. So it's really about acknowledging that we can use some of these other biomarkers up front to help distinguish those individuals with low suspicion, but certainly a patient who's going to benefit from colonoscopy, we shouldn't delay. These patients, even if they are elderly, should ideally get access to this diagnostic tool. With respects to IBD phenotypes in the elderly population, so there's a lot of data that suggests that IBD might behave differently for de novo diagnosis of IBD in elderly populations. Specifically from an ulcerative colitis perspective, individuals tend to have more left-sided disease than a new onset rip-roaring pancolitis right off the bat, which we oftentimes may see with new diagnosis in younger populations. From a Crohn's perspective, thankfully, if it is a brand new diagnosis in somebody in their 60s and above, it typically is patchy colonic predominant Crohn's or Crohn's colitis rather than ileocolonic Crohn's with slightly lower rates for perianal and fistulizing disease versus new onset diagnosis in younger populations. So overall lower rates of stricturing disease and penetrating disease like perianal fistulas. And from a general disease-related complications perspective, very heterogeneous data, mix of retrospective and database and population-based registry data, which I'll speak on a little bit later on in more detail when we go drug by drug or class by class. But in general, elderly patients do have a couple of things that seem to occur in higher rates, including shingles, higher rates for certain infections, including pneumonia, sepsis, cytomegalovirus, as well as candidiasis. And in general, of course, more elderly patients will be at higher risk for all types of malignancies, including colorectal cancer. Patients who are hospitalized, who are elderly, especially those who are unfortunate enough to have a very bad flare of acute severe ulcerative colitis, um, they tend to have higher rates of colectomy. Some data suggesting even twofold versus younger populations. Higher rates of complications, which are potentially related to the severity of their disease, but also could be related to the treatment, such as steroids, which may precipitate delirium, hyperglycemia, hypertension, and a lot of different data that looks at length of stay, cost of hospitalization, that demonstrates the length of stay might be twice as long. And a lot of that data, actually, global data, is actually, proudly enough, data that comes from Canada. Laura Targownik, head of IBD or head of GI at UHN in Toronto, has done some seminal work in terms of length of stay and health economics in the geriatric population. And with all of these challenges, it also portends a slightly or significantly higher rate of mortality overall for the hospitalized IBD patient if they're a much more advanced age, especially those greater than 80 and doing quite poorly in hospital. And then from a surgical perspective in general, the risk for surgery overall for a new diagnosis of IBD in the elderly, if they have Crohn's, is about 22%, about 7.8% in total for ulcerative colitis patients, which, if you're not talking about the acute severe ulcerative colitis who do have a higher rate of colectomy, if you're talking about the general ambulatory population, it can be actually relatively similar to younger adults in total. With respect to treatment trends in general, when comparing elderly to younger populations, interestingly, relatively similar rates of corticosteroid use, higher rates of 5-ASA use overall, lower rates of immunomodulators, but maybe the one that we're going to focus on more is lower rates of biologics and small molecules, or just advanced therapies under that umbrella term, and whether that is an appropriate strategy, whether evidence suggests that is something that is reasonable, or is that something that really should change in terms of how we think about care for moderate to severe inflammatory bowel disease in the elderly in 2026. So at this point, I think I'm going to transition over to my colleague, Dr. Khosla, to shed some light on this topic from a geriatrician's perspective.
Perfect. Thank you, Arif, for the transition, and thank you all for attending as well as for the kind introduction earlier. So, what makes IBD different in the elderly population? Several different things. So, multimorbidity is having multiple conflicting comorbidities. For example, heart failure, maybe cognitive impairment is something that I see a lot. So if somebody has a dementia, are they able to follow the instructions? Are they able, even for a colon prep, or if given a medication, are they able to take it appropriately? So it might not be treatment failure that we're dealing with. Maybe you're seeing non-compliance with medications. Non-compliance might not be the right word because they're genuinely forgetting, but a form of non-compliance. Other comorbidities as well, such as cancer, can have some mimicking symptoms. It can also progress people in their frailty. Shingles or pneumonia cause significant morbidity as well. Polypharmacy leads to an increase in drug-drug interactions, specifically with steroids and other medications. And sometimes we find ourselves getting into a prescribing cascade. What that means exactly is you're using one medication to treat the side effects of another. For example, if giving somebody steroids, their blood sugars increase, and now they're on medications for diabetes. Or their blood pressure increases, and now they're on medications for high blood pressure as well. Medication efficacy changes for certain medications, as Arif mentioned earlier, but older people tend to be more susceptible to side effects. This is due to changes in the way that the medication is, number one, absorbed. It tends to be absorbed more slowly. It tends to reach peak effect more slowly as a result. And sometimes higher doses are needed as opposed to lower doses. It just takes longer to get there. Frailty is something, as well as underrepresentation in clinical trials, that we'll touch on a little bit later, but I wanted to mention it here as well, as it's something that makes a difference. Can you go to the next slide, Ara? I think this is back to you.
Yeah, so we're going to kick off with a case. I'll kind of just describe it rather than going into so many of the details, because we do have a lot of the details on the slides in case anyone wants to expand on or have a question. We can expand on things and loop back. But this is a real patient of mine that I started seeing at the beginning of my practice. in Mississauga. So he was 88 years old, lovely kind of Italian Canadian gentleman. His past medical history, he had UC diagnosed like decades ago. Some other comorbidities. The main one that was actually active was actually his arthropathies. He had osteoarthritis and a total hip arthroplasty, hip replacement a few months prior. Suboptimal ambulation, just recovering from surgery, needed a little bit of NSAIDs. And in the past, he was basically on and off various different doses of 5-ASAs with his previous gastroenterologist historically, but never really required any kind of advanced therapy. It was thought that he had more left-sided disease, Mayo 1 to 2, kind of mild to moderate disease. And he was doing well enough that for about 2 years, he was off of medications. But he got referred to my clinic when I saw him for the first time with a referral that suggested he was flaring after his gastroenterologist had retired. He didn't have access to care. He was having about a flare for whatever that means, flare for about 4 months, about 4 or 5 watery, non-bloody, but urgent bowel movements, typically clustered in the morning, but no systemic stuff otherwise, no major weight loss, joint issues, anemia, or anything like that. And basically, his family doctor had restarted him back on something similar to what he was on in the past. So basically, a max dose oral 5-ASA and some rectal therapy, basically suppositories. And so I ultimately, even though he was 88, I saw him. He was a pretty fit 88-year-old. So we went straight for colonoscopy right off the bat, and he had Mayo 1 to 2 left-sided colitis. He'd been very historically responsive to enemas, and because it wasn't just a little bit of proctitis, I was wondering, okay, well, he's responded to enemas in the past. Maybe that'll get us up to that 25 centimeters. So we continued his oral 5-ASA as he was kind of going in the right direction and started on some enemas. And when I saw him in clinic shortly afterwards, he was going in the right direction, didn't have resolution of symptoms, but he was improving. And so we said, let's just give it a little bit longer. And we felt that there was an obvious trigger because he was taking more NSAIDs, which is something he usually doesn't do. And that was in the context of his hip surgery and some postoperative pain. But then, in the fall of that year, he was truly flaring at that point, 5 to 8 bowel movements, more cramping, couldn't get off of rectal therapy, he was losing weight, and all of this despite being off of NSAIDs. And he was finding it hard to ambulate to the toilet. He was almost having accidents, but not quite. And we were talking about prednisone, for him. Do we need to treat him as if this is a, true, at least moderate flare? But he had suboptimal response previously. We were able to document that, and he was quite fearful about osteoporosis and having a fall and then a fracture as well. So at that point, our plan was to go to advanced therapy. So we at that point we chose vedolizumab. So something that is quote unquote the safest, and we'll talk about whether that's what the real data shows in 2026. But a safe advanced therapy at that point. And I like to bridge my patients if they're already on 5-ASA. We can continue 5-ASA until we get response. But the idea is, could we get this guy onto vedolizumab monotherapy? So we started him on that, and he actually went into clinical remission. He was doing great, fully in remission, but he was hesitant to stop his 5-ASAs. So we said, okay, well, he's still fit. Let's go for a colonoscopy again. If he's in endoscopic remission, maybe then we can stop his 5-ASAs either entirely or gradually, get him on the vedolizumab monotherapy. And we scoped him. He was in clinical remission in September, but he had that weird non-specific 20 centimeters of loss of vascular pattern. Is it Mayo 1? Is it not? Is there inflammation? Is it not? The biopsies were kind of in between as well. Inactive or chronic inactive colitis, which I don't even know what that means still. Like, is that real disease activity? It seems different from when the pathologists say acute, active inflammatory disease. So at that point, what do we do next? Neither here nor there, So he continued in remission. So we said, okay, let's stop one of your 5-ASAs, stop the tablets at least, keep on going with the suppositories and the vedolizumab. He was doing well for a period of time, and then slowly his symptoms started coming back. And on his own volition, he restarted some of his oral tablets, but about at a half dose. And when I saw him in clinic again, we discussed, okay, well, you might be flaring a little bit, mild grumbling symptoms. So we said, okay, let's go back up to the full dose 5-ASA in conjunction with the vedolizumab, and let's ramp up temporarily on the suppositories. And then should we dose optimize vedolizumab as well? And we'll see at the end if anyone has any questions or or thoughts on what the utility of dose optimization of vedolizumab from Q8 to Q4 weeks, which is I'll just say it right now, a very Canadian phenomenon. It's not necessarily data driven, but again, we sometimes do this in Canada based on the perception of safety and then the hopes that it'll provide additional efficacy. And so we did this, and then he felt well for a period of time, and then with the goal of weaning off the 5-ASA. Again, the idea is vedolizumab should be much, much stronger than 5-ASA. It's an advanced therapy after all. But after a period of time, he starts flaring again. This is the spring of last year. He's now having 78 bowel movements again, traces of blood, mild to moderate pain. He's already doubled up on suppositories. We're wondering about enemas again. And really then, we're starting to talk about, do we need to actually treat with steroids? Do we have to talk about a backup plan to get him to hospital to make sure he's safe? And what should we do next? So ultimately, I'll kind of fast forward ahead. We did switch him over to an IL-23 inhibitor. We switched him to risankizumab. We looked at various different advanced therapy options, and overall, he's doing very, very well. And maybe if there is time at the end of the presentation, or maybe we'll chat about it here. Some of the key learnings here. There's certainly a consideration of age versus frailty. So this guy was a little bit more elderly. He was 88, and by the time we got him onto advanced therapy, he's about 89. But he really wasn't all that frail, but he was at risk for frailty. Did I choose the right drug for him? I don't know. He's one of those patients that you tend to reflect on. And maybe, if he was 30 years junior, would I have chosen something different? And now with new data on efficacy and safety, as well as some complementary data about safety, even in elderly, did I actually still choose the right drug for him? Hard to say. We had to consider for this gentleman, he had some individual mobility issues, his joints, his recent hip surgery, his personal fear and risk for osteoporosis had to be taken into account. We had to consider individual issues for safety. Was it safer to hit him with a course of steroids for 2 months? Was it reasonable to consider the beneficial or the relatively benign safety profile of oral and rectal 5-ASA? Or was I just wasting time there? Like, should I have just accelerated to an advanced therapy and maybe a different advanced therapy earlier? Obviously, we have to take into account patient preferences and their own experience. So part of my treatment decision for this lovely gentleman was the fact that he said, Arif, I've done very well on enemas in the past for exactly this type of flare. Should we try it again? And that's very valid information that he had, and we had to acknowledge his experience and think about that as well. Luckily, he was able to tolerate colonoscopy, so we had very good data all the way through. I've thought about this gentleman many, many times, and I actually chatted with him last week, and I do worry now with more recent data, should I have been more aggressive? And I'll show you some data in a second, and we'll see if you guys think maybe at the end of the talk if I should have been more aggressive. But I'll transition back to Dr. Khosla now to expand on some of these geriatric specific concepts.
Perfect. So I think I like to talk about ageism at this point. I'm not saying that Arif was ageist by any means in his approach, and I think not everybody who saw this person would have done a colonoscopy so early. And I think I'd really give kudos to the family doctor. Not a lot of family doctors that I know would start 5-ASA. I think a lot, especially in a city that's fairly well resourced, might wait until the specialist appointment. And if somebody did that, that could have serious morbidity impacts for that patient. When I think about ageism, I see it really as society's last socially acceptable prejudice. It affects a lot of people, about 20% over the age of 50. That's a huge number because when I see 50-year-olds, they don't really think themselves as old. They're still working, they're still vibrant. A lot of 50-year-olds in 2026 have kids who are teenagers or even younger. So by no means are they old. However, maybe once the hair starts to gray, they start to get treated a little bit differently. It's really it refers to our stereotypes. How do we think? Our prejudices, how we feel, or even discrimination. How do we act towards each other based on their age? It manifests in a lot of different ways, and the modern terminology for ageism, or one that could be found more conversationally is gaslighting. And what we hear sometimes in our geriatric clinic is other people in healthcare have talked to people and said, well, what can you expect at your age? This is supposed to happen. You're supposed to forget things. Some IBD specific examples may be, oh, it's just your IBS again. You don't need to worry about it, because not a lot of people know that IBD is increasing in prevalence as people age, or come up with other diagnoses that delay. It's trying to avoid a colonoscopy, saying, oh, it's probably diverticulitis. Let's maybe do a CT scan as opposed to a colonoscopy, or try these antibiotics first. Or, as you get older, you're supposed to lose weight, or another big one, it's common to have incontinence as you get older because your pelvic floor muscles are weak, without going the extra step to say, well, here's what you can do to strengthen them. Can we go to the next slide, please? It manifests in many different ways. Starting there at the left side of the screen, exclusion from clinical trials. We talked a little bit about at the beginning about how this is changing, thankfully. It makes us unclear about what doses to use or how frequently to use medications in older people. It makes us unclear, with the person's declining kidney function as they age. Is this medication appropriate for them, or can somebody tolerate it? Medications can be inappropriate. For example, reaching for something less toxic potentially for a sicker patient, even though it might be less efficacious. The medication that's less toxic might not work, leading to worsening morbidity. People can be denied healthcare. Medical info. A lot of times when people are older, they're not spoken to. The caregiver, their son or daughter, or their much more fit or vibrant spouse is the one who's spoken to instead. All of this together leads to delayed diagnosis, which leads to a delay in treatment, longer recovery, worsening frailty, and we can move to the next slide to see what else. So this is how it can manifest. So we can have slower recovery from the illness, earlier death from worsening mortality, worse quality of life, poor mental and physical health. People think, well, nobody's listening to me, so why should I bother? And then they live more sick for longer, and increased risk of hospitalization and potentially surgery. Can we go to the next slide, please? So we can change the approach. With an ageism lens, we lead to underdiagnosis or misdiagnoses, which leads to under-treatment, and not all options are provided. You're too old for biologics, or you're just getting older. But with more of a geriatric or aging-friendly lens, we can say, well, this is our individualized care. You're much more robust, or maybe you're not looking so good because of the disease, so let's treat it a little bit more aggressively. Let's create our functional goals. So spend a few minutes talking about what the functional goals are. So assess, support. You're not necessarily too old for treatment. The old adage that age is just a number is actually true. Can we go to the next slide, please? And when talking about frailty, I mean, a lot of the times when somebody comes into the office, we can immediately see that they're frail. It might be the way that they look. It might be the muscle wasting that you can see around their face, their hands, or their legs, if they're wearing shorts. Some people think frailty is related to aging. The add-on to that is that in addition to being related to aging, frailty can also be caused by an acute illness, or it can be accelerated by an acute illness. The criteria for diagnosis are there on the left side. It's a weight loss of less than 5% or more of the body weight in the last 1 year, feeling of exhaustion, weakness with a decrease in grip strength, slow walking speed, and decreased activity because of the above, leading to becoming more sedentary. Frailty can be prevented. In somebody who's more robust, it can be prevented with vigorous physical activity to try and improve the physiological declines that are associated with aging, which is on the next slide. It can be prevented by trying to do your best to prevent illnesses, for example, with vaccines. We'll talk about that a little bit more later as well. Frailty makes you vulnerable to adverse health outcomes. It leads to weakness and fatigue, worsens your medical complexity, and really reduces your ability to tolerate interventions. It can impact the functional status as well as somebody's physical reserve and make them more susceptible. Can you go to the next slide, please? So here's just another way to look at it. And on the top, you have your physiological aging changes, which include your decrease in aerobic capacity as you age, or muscle loss, which really falls off a cliff off of the age of 70, a lower bone mineral density, and a slower ability to process information. It's not dementia, it just takes a touch longer. It might be related to hearing. There's a decline in kidney function, as well as slower gut motility. And then somebody's comorbidities. Do they have heart problems, kidney problems, liver problems that might be impacting the way that they look? What we talked about there on the previous slide is on the left. And in addition to what we mentioned on the previous slide, it leads to impaired balance and falls, reduced mobility. And what really bothers people is when they start to lose their ADLs, their activities of daily living. They become much more dependent on others. What does this mean for people? It means there's an increased risk of death from all causes, an increased risk of falls, which often lead to hospital stays, cognitive changes, or fractures. And the more frail you are, if you're somebody who's going for surgery, that can impact your ability to recover afterwards. There's an increased risk of delirium. Delirium itself leads to a significant increase of length of stay. People might not return home afterwards because their cognitive or their function has declined so much. There's an increased risk of steroid toxicity and an increased risk of death, as mentioned. Go to the next slide. This is something called the Rockwood Frailty Index. It's been around forever. I like to show this for a few different reasons. It is Canadian data out of Nova Scotia, and really it gives you a picture of what somebody who's fit or well looks like compared to somebody who might be mildly frail or severely frail. Some of this is a phenotype, what we see when somebody walks into the office, but it doesn't hurt to ask a few extra questions to get an idea of how somebody's functioning at home. A brief basic activity of daily living scale doesn't take long. What are your basic activities of daily living? They're your bathing, dressing, grooming, your ability to toilet, and your ability to transfer. Really, the first 5 or 6 things that everybody does when they wake up in the morning. You can simply ask, are you reliant on your family or PSWs? Or in an IBD relevant question would be, can you toilet on your own? And instrumental activities of daily living, some of them are quite important as well. For example, your medication compliance, your food security, as well as driving. The important thing to think about when assessing somebody is how much of this is physiological versus how much is due to the acute disease. We can go to the next slide.
Excellent. So I'm going to jump back in here. So we're going to jump into a little bit of the more nuanced data about treatments, specifically those for mild to moderate inflammatory bowel diseases, as well as the advanced therapies. And these are very much summary slides. I can expand on any of the data points here, but we'll talk about efficacy and safety specifically as it relates to IBD in the elderly. So, the amount of data that is out there for 5-ASAs, which have been around for ages, is actually quite limited overall. There haven't been any new or revolutionary studies recently, and so quite limited data with respects to comparative efficacy of 5-ASAs in elderly populations versus younger populations that were typically studied. But despite that, it's generally thought that 5-ASAs probably work relatively similarly in elderly overall. Immunomodulators, even less information overall, despite, obviously immunomodulators being used quite often in other immune-mediated diseases like rheumatological diseases in quite high and frequent levels. But from an advanced therapy perspective, anti-TNFs have some conflicting data based on a couple of larger studies, but overall, it's thought that it works generally quite well, anti-TNFs in the elderly. Some studies suggest maybe a little bit more limited efficacy. Some suggest about similar efficacy. Interestingly, about the same rates of antibody formation overall, despite the immune system changing somewhat in elderly patients. And thankfully, relatively high rates of steroid-free remission in those patients on anti-TNFs. One of the things to consider too, when you're talking about efficacy of treatments, we can't just have our blinders on for just inflammatory bowel disease. A lot has been said recently about the fact that the percentage of the percentage of individuals with concurrent immune-mediated diseases is actually very high. So not just ulcerative colitis or Crohn's, but potentially a dermatological issue like psoriasis, atopic dermatitis. Very often issues like concurrent rheumatoid arthritis, psoriatic arthritis, JIA. Elderly individuals are also at higher rates for even vascular immune-mediated issues like giant cell arteritis. And when you look at the list of different classes of advanced therapies here, anti-TNFs are still towards the top of the totem pole for having multiple indications across immune-mediated diseases. And so that needs to be taken into account when you're thinking about efficacy. If somebody is at risk or certainly has more than one immune-mediated disease, it's best to choose one advanced therapy or one mechanism of action that is ideally going to cover multiple birds with one stone. Vedolizumab or the anti-integrins are also thought to have relatively similar rates of clinical remission, endoscopic remission, potentially slightly less efficacious in some trials versus anti-TNF. So something to consider. It's always this balance of efficacy and safety. There's this perception of vedolizumab potentially being safer in the elderly, and we'll talk about that. But there could be slightly suboptimal efficacy trade-off, and so it makes you think, is this elderly individual potentially better suited on an anti-TNF, an IL-23 inhibitor, or even a JAK inhibitor? Now, the data for IL-12/23 inhibitors like ustekinumab has been around for a while. There's been some long-term and real-world evidence data from Unity and trials like that suggest that that works well. But we're just starting to get some RWE, so real-world studies that basically look at populations outside of the phase 3 long-term extension studies that show that both for IL-23 inhibitors as well as JAK inhibitors, in fact, these classes of medications are highly efficacious with absolutely no drop-off in efficacy in more elderly populations versus the typical study cohort. When we're jumping into the safety part, before I go class by class, we do have to acknowledge that there are certain safety considerations that need to be made that might be related to IBD in and of itself. So IBD in and of itself is a systemic inflammatory disorder, and that in and of itself, even for age-adjusted and comorbidity-adjusted cohorts, will carry higher rates of ischemic heart disease. So we will see higher rates of major adverse cardiac events, regardless of what type of therapy an individual is on. And similarly, marginally higher rates of stroke as well, and peripheral vascular disease. Similarly, cancer rates, depending on which cancer you're talking about, can be marginally or even multifold higher in inflammatory bowel diseases. Osteoporosis is, of course, and understandably higher in IBD patients, and specifically elderly patients, possibly due to steroid exposure, obviously due to age as well, but prolonged chronic systemic inflammation is, of course, known to erode bone mass and make individuals more susceptible to osteoporosis-related fractures. And then we were alluding to infection as well. So keep that in mind when we're starting to interpret, safety data overall. But when we're looking at actual classes of medications, it's probably most worthwhile to start off with corticosteroids, because those seem to be prescribed, interestingly, in relatively similar rates between elderly populations as well as average aged populations, despite very, very high rates for osteoporosis, fractures and falls, delirium, which can be very, very hard to treat, other types of mood disorders, issues with metabolism such as hyperglycemia and hypertension, edema, unnatural weight gain that might take longer for individuals to kind of regulate, get back and bounce back to their ideal body weight. We alluded to infection, and so overall, certain studies suggest that in general, elderly populations are upwards of 40% more likely to experience a side effect to corticosteroids versus younger populations. So when we look at the fact that corticosteroid use is relatively similar across age groups, we have to start to consider, should that be the case? Like, given that this class of medication is much, much, much riskier in elderly populations, Of course, there might be a circumstance where we would give an individual corticosteroids, but certainly this idea of steroid sparing and getting onto a very efficacious therapy as quickly as possible to get an individual into remission should be a concept that should be thought about, discussed with patients, rather than just delaying, and potentially exposing an individual to multiple flares and requiring corticosteroids. 5-ASAs, from a safety perspective, relatively similar rates of side effects overall, potentially higher rates of acute kidney injury. Hard to tease out whether that's just due to the fact that they might be flaring, they might be volume deplete with declining renal function, polypharmacy, as well as drugs that could be potentially nephrotoxic. But of course, 5-ASAs do have that potential risk for acute interstitial nephritis as a temporary AKI type of precipitant. From an immunomodulator perspective, there's known GI hepatopulmonary and myelotoxicity overall, whether it's methotrexate or maybe a little less so azathioprine. There is certainly a documented increased risk for non-melanoma skin cancers, as well as lymphoproliferative disorders, more so in the elderly, increased risks for infections, myelotoxicity we were talking about before, and discontinuation rates are relatively high for new onset IBD individuals who are elderly who start immunomodulators. And more so if they are used in combination, not to say that it can't be or shouldn't be used in combination with other advanced therapies, but when we think about the actual data for combination therapies, it's typically with anti-TNFs. It's based on sonic data from a long time ago, decades ago, but it's still quite relevant. The question is, do we need to use combination immunomodulators plus anti-TNFs for a sustained period of time, or should we, which is oftentimes what we do for younger individuals, we might keep them on it for 12 months, 1, 2, 3 years, or should we follow what the data is suggesting, where really that benefit of combination therapy is really just in the first 3 to 6 months? And so if we are making that decision, especially for individuals with perineal fistulizing Crohn's disease in the elderly who might benefit from an anti-TNF, and you really want to get your bang for your buck, if you're going to combine it with an immunomodulator for the elderly patient, maybe do it for a shorter period of time, given the high rates for infections, shingles, versus monotherapy. Anti-TNFs overall, it's really hard to say. There could be a slightly increased risk for serious infections overall, depending on which study you're looking at. But at the same time, there's a lot of heterogeneity of the data overall, and some of the more contemporary data that looks at large registry data across immune-mediated diseases, oftentimes with individuals who are quite elderly, actually does not show a particularly high or different infection rate versus other classes of medication. A bit controversial as to whether anti-TNFs really have more side effects in the elderly population. There is the perception of vedolizumab potentially having lower overall infection risk. One thing that I did not update here actually is an insurance claims-based study that was across many hundreds of thousands of individuals in the States, published actually just a few months ago, that actually showed vedolizumab's infection rate overall, not specifically in the elderly, but just overall, was about actually the same as anti-TNF. So not particularly more beneficial from a safety perspective, and this perception of gut selectivity might be a little bit overblown. And then I was alluding to that there, the conflicting data for infection versus anti-TNFs overall. So some studies suggesting absolutely no difference overall, and then a couple of studies suggesting perhaps a little bit less, but really hard to tease that out based on the heterogeneity of data. So far for the IL-23s, no major difference overall from a safety perspective. JAK inhibitors are a little bit different, higher rates of zoster overall, which is seen across the board for JAK inhibitors, but not hugely so. Most of the studies are looking at relatively unvaccinated populations, and Canadian guidelines certainly suggest that all individuals with a systemic immune-mediated disease should be vaccinated against shingles, and especially those 65 and above, and it's covered for individuals 65 and above. And so it's a bit confounding based on the actual trial data and the real world data. But for the vaccinated population and all elderly individuals on JAK inhibitors should be vaccinated, the absolute increase in zoster exists, but is very mild. confounding data as to whether there is a higher rates for VTE. Thankfully, JAK inhibitors and IBD now um, it has been clarified with more and more and more and thousands more cases that in IBD, even in the elderly, there is not an elevated risk for VTE. But data still persists specifically in the rheumatoid arthritis population because they do use a lot of JAK inhibitors, specifically tofacitinib and upadacitinib, that in that population they might have marginally, ever so slightly higher rates of VTE, but not in IBD, thankfully. And then it is, continuing to be a thing where we are seeing higher lipid levels in individuals on JAK inhibitors, but thankfully both the LDL and the HDL are relatively preserved in terms of comparative levels, and so LDL to HDL ratios seem to be about the same even when going up, and that seems not to increase the risk for cardiac events in the elderly population. And that's further kind of clarified by some recent data in the U.S. registry data from the VA, Veterans Affairs, looking at many thousands of patients in the States with pre-existing cardiac disease who are on JAK inhibitors, and they actually do not see increased risks for heart attack, strokes, which is quite reassuring. From a vaccination perspective, overall, because there are higher risks for opportunistic infections in the elderly, it is quite important that all patients should get vaccinated with Shingrix. Like I said, it's covered, but more so higher rates for susceptibility to pneumococcus, RSV, and COVID. And so I do like to, in my notes, have a family physician checklist, which includes all the vaccinations that are appropriate for all age groups, but also for elderly individuals with IBD. And this is, just, I'm going to skip over this. This is another algorithm that kind of just builds on exactly what we were talking about here. So we're going to quickly go through another case and then kind of wrap up with some key ideas. So this is the second case here. VK, 67-year-old female, ulcerative colitis, diagnosed approximately 5 years ago, which was relatively mild on the left side, but a little bit more active in the rectum. No flares over the last 5 years since the time of diagnosis. And she took some prednisone, but had some side effects back then. She has some other comorbidities, including recent small stroke versus a TIA, with those CT scan findings that are relatively non-specific, with microangiopathic changes. There's consideration for maybe is there a touch of early memory loss or even mild cognitive impairment, but she hasn't been formally assessed just yet. And she's right-hand dominant, non-smoker, ambulatory and totally independent, and she's just on 5-ASA and feeling clinically well. I see her in clinic and she's got some grumbling symptoms that are becoming a little bit more active. No bleeding, but she's getting some watery bowel movements with some urgency, and her CRP is going slightly in the wrong direction. And so our plan was to over and above her oral 5-ASA, add some rectal therapy, get her for colonoscopy, stage her. She's quite functional. Let's see what's going on. But unfortunately, she didn't make it to colonoscopy. She had a stroke as well as a flare at the same time and required admission. So unfortunately, she was found to have a left-sided hemispheric stroke, relatively dense, right-sided hemiplegia in the context of a new onset atrial fibrillation, which required treatment appropriately with aspirin as well as a direct oral anticoagulant. And then she's got some knock-on effects now with her memory, which is much, much worse. She could be confused potentially, or these early signs of progressive vascular dementia. And so geriatrics is involved in hospital. And she's flaring at the same time, which sucks, So 8 to 10 bowel movements per day, incontinence in the hospital, nocturnal bowel movements, and bleeding, and the CRP continues to rise. So we ultimately did a flexible sigmoidoscopy only up to the splenic flexure that shows now more advanced disease, Mayo 2 and 3. So what are we doing next? When we did the in-person kind of meeting, we got a lot of different interesting responses. What was the utility of rectal therapy in this situation? Should we start prednisone, knowing that she has metabolic stuff going on? She's already become quite confused. There was a concern for confusion previously with or mood change minimally with previous steroids. Would we start, solumedrol, as we often do, methylprednisolone in hospital, or right off the bat, could we get her onto advanced therapy, and is that the right thing to do? So her symptoms persisted in hospital, and so we always do the pre-biologic workup, make sure there's no TB, hepatitis B, things like that. Because she was going in the wrong direction, the decision was made, let's just treat her aggressively and see how she does. There's going to be a risk to anything that we do. So we started her on methylprednisolone, but she became quite agitated, unfortunately pulling intravenous lines, ECG lines, with a very hyperactive delirium, and unfortunately now requiring restraints. So she's clearly having side effects to the steroids for an individual who is susceptible to side effects, and so we started her on infliximab, conventional dosing, and she had a suboptimal response. So what do we always do? We just give her more. That's what we always do. We off-label reinduction 4 days later, but she's going in the wrong direction. 10 bowel movements per day, more blood, hemoglobin's dropping. At that point, similar considerations. Is rectal therapy going to help at all? Do you think budesonide would help? Getting some steroid in, maybe it's a little less systemic, maybe a little more enteric. Could that help? Should we try methylprednisolone again because she's really going in the wrong direction? Should we switch to an alternative type of advanced therapy? Infliximab doesn't seem to be working after induction and reinduction. And unfortunately, this patient is at high risk for colectomy. Should we just go for that anyways, and to try to simplify things? So of course, we had to get a surgical opinion, and so the surgeons came by. They provided an opinion about the utility of subtotal colectomy and ileostomy, future J pouch. But she's delirious. Like, how would you leave the pouch alone? There might be some dexterity issues that the husband certainly and the family brought up. They said, well, if she continues to have this dense right-sided hemiplegia, she's probably not going to be able to manage her stoma at all. We're going to have to do this. So this is going to be like a massive, profound impact on her and the family's life. And so we discussed alternative agents and risks and benefits. So we discussed at that point, mirikizumab was the only IL-23 approved for ulcerative colitis. Now, as you guys know, guselkumab or Tremfya is approved as well, Skyrizi, otherwise known as risankizumab. Would vedolizumab work in this case? Patient's pretty sick. The data for vedolizumab and anti-TNF failure is so-so. Is there any utility in trying a different anti-TNF than adalimumab? Or would we consider something like a JAK inhibitor, tofacitinib or upadacitinib? So tofa, Xeljanz, some data 5, 6, 7, 8 years ago of acute severe ulcerative colitis, colectomy sparing, even with biofailure. Granted, they used an off-label dose of TID dosing in the States, and one study in India that actually showed very good rates of colectomy sparing. Or how about Rinvoq, UPA, thought to be maybe a little safer, certainly more efficacious, and studies ongoing at McMaster right now with Neeraj Narula. He's doing a study on acute severe ulcerative colitis and the use of upadacitinib in colectomy sparing specifically. It's a CIHR funded study right now that could, if positive, see upadacitinib on formulary for hospitals across the world. So these are the things that we were discussing with the patient, and more so with the family and the husband. And so actually the husband chose, let's go for Rinvoq. It's a tablet. It's supposed to, seemingly very good data for fast onset, but acknowledging that there are risks. This is exactly what we see in these geriatric populations. We have to think about the person and the trade-offs. This person has a cardiac risk. This person has a VTE risk. This person has a shingles risk, a lipids risk. She's just had a stroke. But there are benefits. Do they outweigh the risks? So there's ease of administration, rapidity of onset, potentially colectomy sparing, and that might be the big one. And so that's what they wanted to go for. So they went with Rinvoq. She got a shingles shot in the hospital, and she responded beautifully well without steroids. And 2 to 3 weeks later, rather, she's in clinical remission, feeling great. And I see her when she's discharged afterwards, and she's on the typical monotherapy dose. She does have, unfortunately, some ongoing mild to moderate vascular dementia symptoms. She is mostly wheelchair bound. She does have some limited ambulation with a 4-wheel walker. Husband is helping as the primary caregiver. And so, we're thinking about long-term planning. What should be her long-term UPA dose? How do we monitor her from a blood work perspective? Do we need to survey her for colorectal cancer? Is this a person where we're thinking about 5 and 10 year outcomes? And how do we coordinate with geriatrics as well as our primary care physicians with respects to clarification of goals of care, how aggressive we should be in terms of treatment, how we should monitor her while taking into consideration her overall goals of care as well as her mobility challenges overall.
It's a perfect transition, thanks for that, Arif, into something that is called intrinsic capacity. This is a different sort of approach to to patients who are a bit more old, maybe a little bit more frail, and it's from the World Health Organization and came out several years ago. The purpose of it is really to identify issues and come up with a pathway to help the patient. In my daily job, it could be identifying a memory issue and formulating a plan to prescribe a medication or talk about a pharmacological intervention. In this scenario, especially after I see them, once their inflammatory bowel disease issues have been managed, it would say, okay, well, things are relatively stable now. How should we continue? There's 5 aspects to it. There's your cognition, which is your memory and thinking. And having a decline in memory and thinking, especially mild, isn't necessarily terminal itself. However, it can lead to people not really knowing how to take care of themselves, which in itself would lead to different complications, or it can lead to weakness from not being as mobile as before, which is the locomotion. The locomotion is really your strength and your mobility. Vitality is your nutrition. Are you losing weight? Are you strong? Are you weak? Your sensory is your vision and your hearing, and your psychological is your mood. There's some shocking numbers that the WHO had found, and one of those is that 66% of people above the age of 76 have impairments in one of these domains. What exactly does that mean? The 2 domains that have the most weight to them are the mobility, the locomotion, and the psychological, the mood. And having an impairment in any one of those, not combined, but any one, can increase the risk of mortality or death from almost 3 to 4 times the higher than the regular population. A decline in mobility, sorry, in an IBD patient, this can progress them across the frailty, lead to more toileting issues. It can lead to difficulty with access to care. We use this really to help formulate different care pathways. So if somebody is having issues with their locomotion, hopefully they're pre-frail, or even if they're able to, during their frail, do whatever they can to maintain their physical activity. If they're losing weight, we have access to dietitians. In Ontario, at least, we have access through Ontario Health at Home to have physiotherapy come to people's homes. Usually it's for 4 to 8 treatments, as well as through dietitians. And this is all covered under OHIP. So there's many different ways that you can intervene on this, and it's important to keep in the back of our minds as we're approaching people. Can we go to the next slide, please? I think I covered some of this, but the early identification of changes is key. It's important to monitor for changes in mood. If you are noticing changes in mood, it's important to address it. So I've noticed you're a little down today. What's going on? A 2 or 3 minute conversation can sometimes go a long way, make people feel like they're not so alone. And if you think it's a significant enough issue, it's easy to communicate either your note or on the phone to the family physician. Nutritional recommendations can be made through a higher protein diet if somebody's able to stomach it, or through a dietitian if available, depending on the province. We can prevent sarcopenia by maintaining or trying to increase mobility, as well as through protein in the diet, as well as stay cognitively active. And what Arif mentioned earlier is vaccines have a significant importance as well. We can go to the next slide. The other thing I like to talk about is the caregiver stress and burnout. This wasn't too much of an issue in the first case because the 88-year-old gentleman was pretty independent. However, it was a significant issue in the second case, and that was pretty evident when talking about stoma care. A caregiver is anybody who's really providing unpaid care to a person in need. Usually, it's a family member. It could be a spouse or a son or a daughter. Sometimes it's a friend or a neighbor. It can really be anybody. It can be direct, which is a hands-on care, to help with things like bathing, dressing, and grooming, or indirect, which is more related to loss or grief associated with a disability. It's increased when providing care to increasingly frail persons. So as somebody progresses through the frailty scale, the caregiver stress tends to increase. It has real impact on people's lives. Symptoms of caregiver stress and burnout include depression and low mood. Oftentimes, caregivers may end up on antidepressants or other medications for their mood on their own. It could be a weakened immune system, making them more susceptible to infections themselves, fatigue, cardiac issues like high blood pressure or poor sleep. Oftentimes, when we think of a caregiver, we think about an older person. You know, a caregiver could be 88 years old. They could be the primary caregiver looking after their 100-year-old spouse who has significant issues. Um, and it's important to keep that in mind as well. So try and ask them about, do you have other family members or friends who can help you out with these things? Can we outsource things like meals or grocery shopping? Can it be ordered online for you? Things like that. This is a different type of approach to older people, really helping them make decisions. So it's a 4M framework. What matters most to you? Is it the shared making? So it's a way to formulate a shared decision-making individualized care plan. It's the communicating with the patients as long as they're able to understand what you're talking about, assuming that their mental status is okay. The medication, talking about what is appropriate in this context. Is this medication have an acceptable side effect profile to you? Does this medication, is it going to work for your disease severity and your mobility? Are you actually able to take the medication on your own with your dexterity? Are you able to take your colon prep for your colonoscopy? We can move on. Think back to you, Arif.
Excellent. Yep. So we're pretty close to the end. I've got one GI take-home point slide, and Dr. Khosla's got a geriatric take-home point slide before we'll open up to any questions or comments. But to kind of summarize, we went through a lot of content actually, and overall, it's important to acknowledge that there's tons of IBD in Canada. There's going to be lots more geriatric aged individuals with IBD that we're going to be taking care of for various different reasons. And the natural history of IBD in elderly is different from other age groups. The cost is higher, to treat these individuals, and healthcare access is more challenging for sure. When we're thinking about choosing treatments, it's always a balance between efficacy and safety, and more good safety data is coming out that suggests that, most of the advanced therapies, basically all of them, are more similar than different actually from a safety perspective. So when you're making a decision for advanced therapies, there are a couple of key points. I find that it's very, very important to first and foremost identify the patient who needs to go on to advanced therapy. If you can figure out who that individual is, time is the essence. So before even figuring out which advanced therapy you might choose, it's just identifying that patient and getting them onto it quickly. And the reason why time is of essence is, all the data for all individuals with IBD suggests that the longer you wait to get somebody on a good advanced therapy, the worse their outcomes are going to be. And the quicker you can get somebody with moderate to severe inflammatory bowel disease onto good therapy, the higher the chance that you can change the trajectory of their disease. And I believe that's probably even more profound with individuals who are more elderly. These individuals are much more likely to lose muscle mass, to become frail, to have other complications, to have hospitalizations and not bounce back as robustly. And so the stakes are higher. So rather than kind of going low and slow for elderly populations, I think we need to start considering, especially with this relatively reassuring safety data across all classes, should we actually be going more aggressively in the right population, in those individuals who are very likely to need a biologic. And then when you choose a biologic, there's we're lucky we have many good biologic classes. So we can use something that is theoretically gut selective, knowing that yes, that might be more of a catchphrase than anything, but vedolizumab does have excellent efficacy and a good track record. The IL-23s are very, very good overall. JAK inhibitors are remarkably safe. Anti-TNFs still have by far and away the most indications. And a lot of these individuals might have concurrent immune mediated diseases or at risk of that as well. So it's really about, personalizing your choice to that patient in front of you. And as you personalize, a recommendation for that patient, it certainly benefits the decision making to collaborate with the patient, with the family, with the caregiver, and certainly with geriatrics as well. To personalize that approach, come up with a good decision that works based on some nuanced challenges that might exist for that patient. Oh, Shiv, I think, yeah.
Yeah, no, that's better. So the geriatric take-home points, the slide didn't update, but essentially I would want to echo the personalized approach. I think that's most important. We often think we know what the patient wants or what's best for the person, but it's important to list out the different options and have them at least understand the decision, why you're making it, or if they don't agree maybe an alternate approach and have a very robust discussion that way. Um, what the other thing is, what's causing somebody to look frail? Is it their physiological changes? Is it their multimorbidity? Or is it the acute issue in front of us? If somebody's looking like that, if it's something that we think we can reverse, we shouldn't hesitate to investigate. We shouldn't hesitate to treat, assuming an okay prognosis and safety profile of the medication. I want to say something I said before as well, that age is just a number. Sometimes we see I've seen a 107-year-old who looks a lot more healthy than a 67-year-old. And echoing again what our said, a multidisciplinary approach is key. I lean very heavily on my colleagues, whether it's other specialists or family doctors as well. I'll always say that the phone is the most underused resource that we have. Everyone carries one in their pocket now, but it's sometimes hard to pick up the phone and call other people. We use physio and occupational therapy to help people maintain or improve their function, and dietitians for people who are losing muscle mass or losing weight. Also, keep in mind not just the patient, but the people around the patient. And we've gone so far as to call that person's family doctor and say, I'm really worried about this caregiver. They're in a super stressful situation looking after the loved one because of X, Y, and Z. So those would be the geriatric take-home points.
Excellent. So I'm going to, end the slideshow there and um, open it up to Noelle or any of other participants today to see if anyone has any questions or comments based on the content from today.
Great. Thank you both very much for your presentation. It was so comprehensive and holistic, so very synergistic to have both presenters. So thank you so much for that.
Thanks for having us.
We will open it up to a few questions. So there are a few ways in which you can ask questions. So one of them is in the chat. Please feel free to ask questions in the chat, and I can relay those questions to our speakers. Or if you would like to present your question yourself, you can raise your hand and we will unmute you. So we'll just take a moment here for any questions. Okay, so we do have a question, a long question in the chat. Thank you so much for that. Okay, so I know Drs. Yusuf and Khosla can see the question. Would you like me to ask it so that everyone can, or would you like to just speak to it and ask it and speak to it? Is there a preference? I'm just giving them a moment because it is quite a. Okay, let me just go ahead and I'll read it so that the entire group. So the first question is, per up to date with regards to sulfasalazine with the eGFR of less than 60 mils per minute, and in the context of IBD, data on the safety of oral sulfasalazine treatment in patients with pre-existing kidney disease is lacking. It may be reasonable to avoid use if possible in patients with pre-existing impairment. If necessary, Use with caution and utilize the lowest effective dose. Monitor kidney function frequently, especially during flares of IBD, which could precipitate dehydration. My goodness. Um, let's see. I'm as I'm reading this, I'm not sure if there's a question or this is just more of a statement.
No, I can
Um,
speak to that, Noel.
okay,
So
okay.
I think the question really is, you know, you know, for or at least the way I interpret this question is the following, especially one of the first slides that I showed that, asked people to think about what they would reach for mild to moderate disease phenotypes and specifically for Crohn's, and what we would choose in the elderly. And oftentimes, what we see is there's a hesitancy to move, especially in those individuals with moderate kind of in between disease, hesitancy to move to advanced therapies and use some type of suboptimal therapy for quote unquote mild to moderate disease. Because really, Crohn's doesn't really have a good true equivalent to a 5-ASA, which is more efficacious in my perspective for ulcerative colitis, and most people would agree with that. But we sometimes will use a 5-ASA. Sometimes we'll use sulfasalazine in Crohn's as well, because there might be ever so slightly more data. And actually, Health Canada does approve sulfasalazine technically for Crohn's disease still, or an immunomodulator. And I kind of group all three of those: sulfasalazine, methotrexate, and azathioprine is generally suboptimal drugs, especially if somebody's in the in between area. So to Anna's question, should we be highlighting the fact that although we're kind of just practicing and sometimes giving these drugs because they seem more benign, should we be highlighting the fact that they're not actually that benign? And at least compared to advanced therapies, the side effect profile of some of the advanced therapies is actually more favorable, more beneficial. So, I would, the way I approach this type of situation is individuals with Crohn's, like who might just have very, very, very mild disease. It's okay to just monitor a little bit if they're feeling fine, or try them with a lot of monitoring on one of these quote unquote suboptimal therapies. But for those individuals who have a reasonable likelihood of requiring an advanced therapy, I wouldn't stick around too long with these types of therapies like sulfasalazine or immunomodulators. I would go on to trying to get them qualified and approved for an advanced therapy, given the fact that the safety profile for those is actually much, much better. So I don't know if that answers Anna's question, but that's how I kind of interpret that.
Great, thank you. And there's a secondary question related to the discontinuation rates of immunomodulators. So that rate that was presented was 67% is high. Do you know why people are discontinuing?
Yeah, so I'd say I usually counsel my patients that who just initiate immunomodulators within the first couple of months. Discontinuation can be as high as 20 to 25% within a short period of time, even within the first couple of weeks. And the initial discontinuation is typically due to GI toxicity, nausea, vomiting, generally feeling yucky. Then after that, as we start monitoring a little bit more, that's when other issues start coming into play, such as myelotoxicity, falling RBC counts, falling WBC counts, so leukopenia, things like that. And that starts to creep in typically after 1 to 6 months, and hence why we should monitor individuals quite closely who do start immunomodulators. So that's kind of the big bulk of why individuals might be discontinued off of immunomodulators. There is theoretically the concern for azathioprine, especially in the elderly, of rare toxicity such as hepatosplenic T cell lymphoma, which is an incredibly rare form of lymphoma, but essentially fatal. Tends to happen slightly more so in males, and more so in elderly populations. And so often there is a push for even those individuals who are tolerating azathioprine in younger populations who've been on it for 5 or 10 years, to see if we can get off of that medication for something with a more favorable side effect profile overall. So I think it's all of these kind of short, medium, and long-term toxicity concerns that lead to a total discontinuation rate at some point of about 2/3.
Great, thank you for that response. Are there any other questions? Okay, let's see here. So there's another question. For lifelong IBD patients who are hitting 50s, when would you start to suggest bone density test screening for those that have had repeated steroid courses in their lifetime?
That's a fantastic question. Um, and we don't actually know everyone's individual response will be different. I think for I think any individual based on cumulative duration of inflammatory bowel disease is at risk even before 50. And oftentimes some of the endocrinology data will suggest that a baseline BMD well before 50 might actually be beneficial. So if somebody, for example, has been diagnosed in adolescence or in their teenage years, if they, I almost start to think about it, how we conceptualize dysplasia screening. When we're starting to think that after 8 to 10 years, there's a cumulative risk for colorectal dysplasia, even in a young individual, the same kind of process in essence is happening to bone. And especially for individuals who've had a rocky road with on and off inflammation, which is going to cause thinning of the bones, but also potentially multiple courses of steroids. And so certain endocrinology societies have started recommending that even as early as 30 or 35 years old, 40 years old, getting a baseline BMD just to see where you're at. And if all is good based on that baseline BMD, then around the 50s mark is a reasonable time to start considering bone mineral density scanning on a regular basis. But the reason why they're saying that, consider it early, even as early as 30s and 40s for some individuals with long-standing IBD as well as cumulative steroid exposure is that there is going to be a subset of individuals who are young that will actually find osteopenia. And those individuals, well, they might actually benefit from referral to, an endocrinologist early on, to monitor a little bit more closely, come up with a more customized and personalized screening and surveillance approach to bone health. Certainly, optimization of simple things like vitamin D and calcium, maybe some personalized recommendations in terms of weight bearing exercise to improve bone mass. So I put it again in my checklist at the bottom of all of my notes of things to monitor, which includes vaccination, smoking cessation, mental health, dysplasia surveillance. I put a bone mineral density as early as 35 years old for a one-off.
Great. Thank you very much for that response and question. I don't see any further questions in the chat. We'll just give one moment here, just in case there are any last-minute questions. Well, once again, thank you so much, Drs. Yusuf and Khosla, for your time and your presentation on aging and IBD. Thank you also to our sponsor, Organon, as well. And thank you to everyone for joining us tonight. We really appreciate it. This presentation will be made available to you as a recording later on. So thank you very much, everyone. Have a good evening.
Thank you all.
Thank you.